We are live now.
Good evening, everyone. We are honored to extend our warmest welcome to all of you on this day of International MPS Awareness. Strand Life Sciences is delighted to support an insightful webinar on MPS organized by the Rare Disease India Foundation. Every year, May 15th is marked as International MPS Awareness Day. MPS stands for mucopolysaccharidosis. These are a group of inherited metabolic diseases classified within a large group of disorders called lysosomal storage diseases.
Can you hear me?
Today, through this webinar, we intend to touch upon some of the aspects and facts about MPS and creating awareness around the same. Thank you all for joining us for this important event. Can we move next?
Yes, 1 second.
Okay. Okay. Starting off with our first and important person for this webinar today, I would take great pleasure in introducing Dr. Saurabh Singh. He happens to be the co-founder and chairman at the Rare Diseases India Foundation. He has actively been campaigning the cause of rare diseases for over 8 years now. He has worked generously to create awareness for rare diseases in the country. He has played a very important role for the National Rare Disease Policy in India. He is the person who has consistently been advocating for an effective rare disease policy. He has passed the NCC C certificate and also was recognized by the Honorable Prime Minister of India in 2000, Governor of Bihar in 2000, Union Health Minister of Jharkhand, and the Governor of Jharkhand in 2022, and also by the Member of Parliament. Mr. Saurabh is also awarded several times in the field of rare diseases on different platforms. I think the reason his journey started off in rare diseases is because his son was suffering from one of the rare diseases, which is MPS II, and his journey has been towards fighting for this cause ever since. Dr. Saurabh has done an MBA and he has worked over 14 years in various multinational companies. It is a great pleasure for us to have you here, Mr. Saurabh. And I would like to ask Mr. Saurabh to present the welcome note now.
Yeah, Mr. Saurabh is having some issues with his speaker. He's just joining.
Yeah,
we can just, yes, hi, Mr. Saurabh.
Yeah, right. It is okay with me.
So, Mr. Saurabh, we would like to give you, we would like you to say a few words about your organization.
Yeah, good evening, everyone. I'm Saurabh Singh, co-founder and chairman of Rare Diseases India Foundation. First of all, I would like to welcome all the experts who are there on this occasion of MPS Awareness Day. And also thankful to Strands who are supporting us for this cause. So I wholeheartedly welcome all our eminent speaker, moderator, and attendees who are there and who are there with us today from the different corner of this world. So RDIF is a patient advocacy group. It is established in 2019 actually, and this is a non-profit organization to raise awareness about the rare diseases in the country. So as we all know that rare diseases are very few in numbers and mostly it is genetic. 6 to 8% of population of India is affected with rare diseases and 72 to 96 million people is affected with rare diseases. So either there is no treatment available in India or the treatment is unaffordable by an individual, which are generally comes in crore. I mean, the cost of the therapy comes in crore. So to diagnose these diseases in early stage is also a major challenge because the symptoms of these diseases generally appears after 2 to 3 years of age. So lack of awareness about rare diseases, including medical fraternity and the general public, is also one of the major challenges in this country. government does not support fully in these diseases due to high cost and lifelong therapy is not supported by the government nowadays, which we are seeing. So we all know that in the month of March 2021, the government of India has formulated a revised rare disease policy, but that too is not very much effective, especially for group 3 diseases, which includes lifetime treatment, and these treatment are very expensive. Families are bound to watch their child dying every day. So to discuss all these issues, we have the expert doctors here. And one more thing, and we are very thankful to God that today we have a rare disease warrior, MPS 1 patient, Mr. Akash from Jharkhand, who is no more a rare disease patient after the medication of this disease. He is leading a normal life. He is pursuing LLB and doing a very well in life. So I also want to introduce with Akash. He's the patient of MPS 1. So, Mr. Akash.
Yeah. Good morning, sir. Good morning, ma'am. My name is Akash Prasad. I'm from Jharkhand, Ramgarh. सर मैं तो अभी एक MPS फाइटर हूँ फिलहाल आप सबके लिए। मैं एक MPS पेशेंट हूँ। मेरा थेरेपी एम्स के तरफ से चल रहा है और मेरा डेट ऑफ बर्थ 20 दिसंबर 2002 में हुआ था और मैं एक नॉर्मल चाइल्ड था और इसमें एक होता है अपने सारे नॉर्मल बच्चे जैसे होते हैं ना, वो मैं उसी तरह का हुआ था। मैं एक नॉर्मल बेबी था और अप्रॉक्स 4 kg का था, मैं नॉर्मल था। उसके बाद सर मैम हुआ क्या कि मेरे साथ 1.5 साल का था मैं, उसमें मेरे साथ एक हार्नी अपेंडिक्स का ऑपरेशन हुआ उसी पीरियड में। उसके बाद से थोड़ा मेरे साथ कॉम्प्लिकेशन मेरे साथ आने लगे और कॉम्प्लिकेशन में मेरे फिंगर्स, मेरे जॉइंट पेन वगैरह मेरे साथ होने लगा। उसके बाद मैंने धीरे धीरे फैमिली में मेरा ट्रीटमेंट भी स्टार्ट हुआ। मेरा देखा गया कि क्या है, नहीं ये बच्चे करवा लेते हैं। तो रांची में, रामगढ़ में बहुत से डॉक्टर्स मुझे देखे और इसी दौरान मेरे पापा का जॉब था सीसीएल सेंट्रल कोलफील्ड लिमिटेड में, तो अपने गांधीनगर रांची में मेरा ट्रीटमेंट हुआ, सबसे पहले स्टार्ट हुआ था वहाँ पे। तो वहाँ पे भी कोई डॉक्टर थे, वहाँ के डॉक्टर्स भी नहीं समझ पा रहे थे कि मुझे हुआ क्या है। तो कॉम्प्लिकेशन तो था सर मेरी लाइफ में बहुत ज्यादा, और कॉम्प्लिकेशन के साथ ही वहाँ की मैम एक थी डॉक्टर जे आर्या मैम, वहाँ की, उन्होंने बहुत ज्यादा सपोर्ट किया था उस टाइम पे, क्योंकि उन्होंने सबसे पहला मुझे माना जाए कि क्योंकि वेलोर उसमें बंद हो गया था, सीसीएल कंपनी ना ट्रांसफर नहीं करती थी, तो उसमें मैम, मैं एक लौता पेशेंट था उस बीच में मुझे मैम ने ट्रांसफर किया था। और इसी बीच मैंने वेलोर में ट्रीटमेंट स्टार्ट हुआ था 2008 में मेरा ट्रीटमेंट स्टार्ट हुआ और ट्रीटमेंट में वहां पे डायग्नोसिस किया गया तो मुझे पता चला कि मुझे MPS 1 है। अब मैं उस समय बहुत छोटा था, उतना तो मुझे नॉलेज में नहीं था कि क्या है ये डिजीज में। और वहां पे मेरा 2009 में मेरा एक ऑपरेशन हुआ था पैर में, उसमें एक बोन है, वो आपका जो बड़ा सा गोल सा आता है ना, वो एक बॉल है, उसका ऑपरेशन हुआ मेरा। 1 साल अप्रॉक्स में चला नहीं था, प्लीट लगा था पैर में। और उसी समय हुआ क्या कि पता चला था मैं कि नहीं तो ये दवाई की कॉस्ट बहुत ज्यादा है, मतलब अफोर्डेबल नहीं था, एक मिडिल क्लास फैमिली के लिए अफोर्डेबल आज भी नहीं है। और मैंने वहां से मुझे भेजा गया फिर एम्स, और एम्स में आने के बाद हुआ क्या कि मेरा पता चला कि MPS 1 वहां पर ही बोला गया कि MPS 1 है, और इसका डायग्नोसिस के लिए दवा के लिए तो बहुत मुश्किल हो रहा था, मैं दवा मिल नहीं पा रही थी क्योंकि कॉस्टली ही था इतना ज्यादा कि हम लोग अफोर्ड नहीं कर सकते थे इसे। फिर से हुआ क्या कि मेरे साथ कॉम्प्लिकेशंस मेरे साथ ज्यादा थे, और मैं देखता था कि मेरे फ्रेंड्स हो गए और सब नॉर्मल है और मैं एक नॉर्मल नहीं था। उसी बीच में हुआ क्या कि 2014 में मेरा ये मेडिसिन शुरू हुआ, और इसी बीच क्या बोलते, थोड़ा सा लाइफ हल्का मेरा चेंज हुआ उसी बीच में, क्योंकि मैं अभी BLLB सेमेस्टर 8 में हूँ, और जाहिर सी बात है मुझे अच्छा लग रहा है क्योंकि मेरा लाइफ चेंज हो गया है। और आज के डेट में मैं सब मुझे मेरे मेरे तारीफ करते हैं सब कोई लोग, क्योंकि मैंने अपने आप को खुद बदला है। और ये दवा बहुत अच्छा है क्योंकि मैंने ये इसे देखा कि अपने अपने आप में बदलते हुए कैसे बदला जाता है। ये दवा लगाने के साथ साथ ये एक जरूरी है बॉडी में एक फिजियोथेरेपी, एक्सरसाइज और डाइट इसमें बहुत ज्यादा जरूरी है। ये दवा लगेगी तो इसमें डाइट वगैरह लेना है और फिजियोथेरेपी इसमें बहुत ज्यादा जरूरी है। इसके साथ साथ मैं कुछ दिन से, वही 2 साल 1 साल से मैं बहुत सारे गरीब बस्ती गांव में मैं घूमा हूँ, वहाँ के लोगों की मदद किया हर तरफ से। जैसे दिवाली है, दिवाली में मिठाई, कपड़े, थोड़े बहुत बच्चों के लिए खिलौने, ये सब देखा है। मैंने गया हूँ, मैं 1-2 साल से मैं किया हूँ। वहां पे मैंने देखा कि बहुत ऐसे छोटे छोटे गांव हैं इंडिया में, पूरे झारखंड, बिहार, उड़ीसा, ये सब कुछ स्टेट है जहाँ पे छोटे छोटे गांव में देखा हूँ कि मतलब वहां पे अगर ये डिजीज है तो वहाँ के लोग इस डिजीज को पता नहीं कर पा रहे कि हाँ ये एक्चुअली में क्या है। वो छोड़ देते हैं नॉर्मली बच्चे को, और बच्चा क्या है इसका लाइफ वो सरवाइव नहीं कर पा रहा है। मैंने ये देखा है और मैं चाहता हूँ कि मैं ये लॉ फील्ड से कुछ अपने से हो कि मैं दवा ये सब गरीब बच्चों के लिए मैं करवा सकूं। ये मेरा सपना है, अपने लिए मैं करना चाहता हूँ ये। हेलो।
थैंक यू आकाश जी, हमें बहुत खुशी हुई कि आप यहाँ आज हमारे साथ जुड़े हैं।
yes,
और आप ये अवेयरनेस, आपकी कंडीशन, आपके जर्नी की अवेयरनेस हमारे साथ शेयर कर रहे हैं, और आपकी विलफुल जो स्पिरिट है फाइट करने की, वो हमारे साथ शेयर कर रहे हैं। और I would also like to thank Mr. Saurabh for his contribution. I'm sure the rare disease community is extremely grateful to him for his contribution and perseverance to this community and this field. Now, I would like to introduce the moderator of today's panel discussion, Dr. Sakshi Rajoria. Dr. Sakshi is a consultant pediatrician and clinical geneticist at Jeevan Jyoti Hospital in Prayagraj. She is also a pediatric clinical geneticist at Trishla Foundation for Cerebral Palsy Children, also in Prayagraj. She is a specialist in pediatric intensive care, neonatology, and genetics in prenatal, pediatric, and adult conditions. She has had immense experience as an assistant professor at the Department of Pediatrics at SETH GS Medical College and KEM Hospital in Mumbai, at Genzyme SIAMG Fellowship in Clinical Genetics at Sir Gangaram Hospital in New Delhi. She has had the observership at the Department of Medical Genetics at Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow. She is the member of Indian Academy of Pediatrics, Indian Academy of Medical Genetics, Indian Society for Inborn Errors of Metabolism, Indian Society of Assisted Reproduction, and the Indian Society for Prenatal Diagnosis and Therapy. Talking about her educational background, she has done her MD Pediatrics from Lady Hardinge Medical College and Associated Kalavati Saran Children's Hospital from New Delhi. She has been the fellow in clinical genetics from SETH Medical College and King Edward Memorial Hospital in Mumbai. She received the MRC-PCH membership of the Royal College of Pediatrics and Child Health. She has been the senior resident at Department of Pediatrics from SETH GS Medical College and King Edward Memorial Hospital. Thank you so much, Dr. Sakshi, for being here with us today. I request you to commence the panel discussion and take this webinar forward.
Thank you so much for such a warm welcome. Good evening, everyone. Hope I'm audible.
Sakshi, just keep the introductions short. Just say the affiliations and move on. We can't waste so much time in introducms. Okay, just one line. Okay.
Yeah. Okay. So at the onset, thank you, Dr. Saurabh Singh and Rare Diseases India Foundation and Strand for giving me this opportunity. It's an honor to be here in between these esteemed panelists. I would request all the attendees to type your questions in the Q&A chat box whenever you have any questions in mind. Moving on, I would like to introduce our panelists for today. Dr. Veronica Arora. She is consultant, clinical geneticist, and assistant professor at Institute of Medical Genetics and Genomics at Sir Gangaram Hospital, Delhi. She is MS
move on. That's enough. That's enough. We're already running very late, Sakshi. We're running very late. Yeah.
Yes. Okay, ma'am. And introducing our second panelist. Could you please move on the slide? Dr. Priyanshu Mathur. He is consultant pediatric rare disorders and metabolic genetics at the Pediatric Rare Disease Clinic, J.K. Loyan Hospital, SMS Medical College, Jaipur. He is also a visiting assistant professor at Emory University School of Medicine. We are very grateful to have you, sir, here. Our next panelist is Dr. Meenakshi Lallar. Can I have the next slide? She is a clinical geneticist at Prime Imaging and Prenatal Diagnostics, Chandigarh. She is also a consultant geneticist at Medgenome Labs. She is DM from SGPJ Lucknow and was former consultant in Sir Gangaram Hospital. Introducing our last panelist, Dr. Mayank Nile. Can I have the next slide? He is assistant professor and consultant pediatrician at Department of Medical Genetics, Postgraduate Institute of Child Health, Noida. Sir is also DM Medical Genetics from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and ex-assistant professor at SGPGI, Lucknow.
Thank you. We can proceed. Yeah.
Yes. Thank you so much, all panelists. Now proceeding to the panel discussion. Can I have the...
Yes, I'm presenting the slide.
Yeah.
Is my slide visible?
Yes, Ananya. Yeah. Can we go on to the next slide and start the panel discussion on the... Yeah. So starting, Dr. Veronica Arora, how do we identify mucopolysaccharidosis and how do we classify them? Ma'am, over to you.
For your question. Thank you, Sakshi, for preparing these questions and the presentation. So,
my honor.
All of you and all patients, all doctors to be a part of this program today. Our main aim is to basically interact with you and answer if there are any questions. So mucopolysaccharidosis is a subtype of lysosomal storage disorders, and these disorders are caused due to accumulation of certain long sugars in our body, because the enzyme that is present in our body to break these long sugars is absent in these individuals. So the enzymes that are present in the body do not function, and that's why there is accumulation of a material called glycosaminoglycans, or in short called GAGs. So all the features of mucopolysaccharidosis is due to the accumulation of the GAGs. Now, if these GAGs are accumulated on the face or the skin of the individual, they look a little coarse, meaning thereby that there are dysmorphic features and they have thicker lips, larger heads due to accumulation of these toxic substances. They may get accumulated in the brain, causing certain intellectual disabilities, developmental delays, or in different parts of the body like liver, spleen, heart, etc. So wherever these get accumulated, there is a problem or increase in size of that organ. So that's why this is known as a storage disorder, because there is a storage of abnormal material that is present. Now, the classification is basically on the type of enzyme defects that is present. Till now, we had MPS 1, 2, 3, 4, 5, 4, and there was no MPS 5. And then we have MPS 6 and 7. The numbering is really just based now on the type of enzyme that is deficient. We also have another discovery of an MPS 10, which is caused due to a mutation in ARSK gene, which has been recently discovered. And of course, as science progresses, there can be many more types. The major organ systems again, I'll just summarize, would be the CNS, the cardiovascular system, and the liver that is affected by this group of disorders. So children who look a little coarse or dysmorphic, have intellectual disability, short stature, any sort of skeletal involvement, we should look for an MPS in them and do very easy tests for diagnosis, which will be discussed shortly.
Thank you so much, ma'am, for explaining the pathogenesis and what lies in a child with mucopolysaccharidosis. Going on to the next question for Dr. Priyanshu Mathur. Kindly enumerate, sir, the common clinical features which are seen in MPS patients.
So thank you, Sakshi, for the question. So as Dr. Veronica already told, they usually have a core spatial features. So the majority of MPS subtypes have a core spatial features, except that they are subtle in Sanfilippo disease. They can have short stature because of delay in skeletal development. Then they can have intellectual disability. They can have hepatosplenomegaly, organomegalies. Then corneal clouding can be there. They can have leukocyte infusion bodies. They gradually develop joint contracture, which are very classically seen in these patients. Then the dysostosis multiplex is seen in these patients. Dysostosis multiplex includes various skeletal changes, which are very characteristic of mucopolysaccharidosis, such as J-shaped sella turcica. They have a O-shaped ribs. They have vertebral changes, anterior weakening of the vertebra. They can have kyphoscoliotic changes. They can have changes in the ilium bone. Ilium bone can be more pointed towards the downside, and they can have poorly formed acetabular cavity. Apart from that, they can have changes in the long bones also. So these are the features which are commonly seen in the MPS patients.
Thank you so much, sir. It is a multi-system disease, and sir has told the various systems which can be involved. Moving on, Dr. Meenakshi, since so many complications can also occur, can you please tell us the common complications and how they can be managed? Dr. Meenakshi.
Thank you for the question. So the complications are going to be accordingly as the system is going to be affected, because we know it's a multi-system disease, because the multiple soft tissues are associated with the storage and in the accumulation of the GAGs. So most of them have the same complications. So most of them will have complications ranging from CNS. There would be ventriculomegaly, a large size head, ventriculomegaly, and there would be because of the ventriculomegaly, I'll be discussing the management now. So you might want them to follow with the neurologist, and shunt placement might be required. Sudden decompression should be taken care of. Then coming down, they should be in follow with the ophthalmologist, because there some of the MPS have corneal clouding. They might, because the vision might be impaired, they might need corneal replacement, lamelloplasties. Then due to increase in the pressure in the brain, there can be optic nerve atrophy, optic nerve head dysfunction, retinal changes leading on to glaucoma, both open and closed angle, and this can lead to blindness. So again, a multisystemic involvement, multidisciplinary follow-up. The soft tissue of the airways are very commonly involved. These patients suffer from a very range of sleep apneas, which makes it very discomfortable. From the sleep is very uncomfortable for them. They have this snoring, daytime apnea, sleepnesses. So for this, sometimes the ERT helps, and sometimes you have to put them on CPAP initially for the night and during the daytimes as well. Ultimately, some of them do land up with tracheostomies as well. The hearing is involved. Then the oral cavity is especially involved in the hunters, where there is a ankylosis of the temporomandibular joint. There is a macroglossia, that is a problem itself. Then the skeletal system, we know there are contractures. Then the spine becomes kyphotic, and there is nerve root entrapment at various levels. So you might need decompressions at this. So most of them have the common manifestations. The heart is involved. Most of them have arrhythmias, cardiomyopathies, and heart failures eventually. So these are managed symptomatically. They have alternating diarrhea and gastric complaints as well. The oral health has to be taken care of. It is very important a multidisciplinary approach is followed up, because if they frequently need surgeries. So what has to be done that in these patients, anesthesia is a very, very big problem, because the neck placement during the anesthesia is a problem. What they tend to do is ensure in one sitting 2 or 3 surgeries procedures are taken care of. And especially for the MPS type 4, we would want atlantoaxial joint surveillance, and they should be guarded against high impact sports, and the support to this joint is very vital. And most of them should have a very regular surveillance with the multidisciplinary specialties.
Thank you so much, ma'am, for elucidating all the complications very in depth, and telling us the management and how all of them are linked, and having a multidisciplinary care is so important in such children. All clinical geneticists along with physiotherapists, anesthesiologists, and everyone is involved. Now coming on to the next question to Dr. Mayank Nile. Sir, can you comment on the age of onset of these various common symptoms that we have described? And in our clinical practice, there is this spectrum of disease which we see. So can you please throw some light on this?
Yeah, thank you so much. Hope I'm audible. I would like to share one slide. I hope my screen is visible. I think you'll have to stop.
Yes, sir. Yes, sir.
Why I want you all to go through this case is because the spectrum of such mucopolysaccharidosis disorders is very important. It is also important for an early diagnosis, because as with other genetic disorders, we also know any early diagnosis is very important. And when treatment is available, of course, an early diagnosis helps in preventing the irreversible damage. So to know about this case spectrum, this was a full-term male child who was normal at birth. At 10 weeks of age, the baby was having bilateral gular hernias. So basically in first year of life, the child had presented with recurrent respiratory infections, watery diarrhea, and the family was basically concerned about all these things. So initially to a pediatrician, if such a case goes, they will think, okay, let us see, it might be an infection or something like that. But gradually, around 5 years of age, the child started showing the typical facial dysmorphism, which already told by previous speakers, like coarse faces and all, and his growth also began to slow. Again, the child was also having some lack of flexibility, which already told like contractures can be there. And this was again, the pediatrician was not very sure. He was like, okay, let us see. And also the child also developed hearing loss. Hearing loss is universal for most of the mucopolysaccharidosis. And then this child was also presenting the same thing. Ultimately, because of the difficulty in the motion, the child was referred to a pediatric orthopedician. And the orthopedician examined, and he found the child had stiff joints, slow growth, short stature, dysmorphism, and all those things which are typical for an mucopolysaccharidosis. Then the child was referred to a clinical geneticist, and then lab tests confirmed the diagnosis. So this child got a diagnosis around 8 years of age. Why I want to stress on this is that in various worldwide studies, it has been shown that most of the typical features begin around 2 to 3 years of age. But you can see unawareness or not having a proper knowledge about the disease had led to a delayed diagnosis for this family. So I think that is also the motive of this webinar, is that an early diagnosis is very important. So we should know the red flag signs which can be diagnosed early and seen in the patient. So when should we consider? The child are typically normal at birth. Already told before, these are chronic progressive disorders. Initially, they may be normal, but gradually all these typical features occur with age. And again, as already told, there are different types of mucopolysaccharidosis. We should think for a broad classification, if there is a visceral involvement like hepatosplenomegaly, skeletal changes, and may have certain CNS features, we have to think about MPS 1, 2, 6, and 7. Mainly if they are having typical neurodegenerative features, then Sanfilippo is to be considered. And when we are thinking about a skeletal dysplasia, short trunk, typical skeletal changes, then we should think about MPS 4. And these things are already discussed. I want you to focus on this slide. Yeah, as already told before by Dr. Priyanshu, the typical dysostosis multiplex or the skeletal changes, you can see widening of the ribs can be there, and there is deficiency in the anterior body of the vertebrae, and typical J-shaped cellular tarsica can be there. Proximal tapering of the phalanges is also typical. So all these things, if there is present in the child, they can be a feature of MPS. Similarly, for MPS 1, there can be 3 spectrum. As with other MPS, there can be a severe form or an attenuated form. When we especially discuss about MPS 1, the severe form in which the symptoms present at an early age, you can see the life expectancy also decreases, and it is known as the typical hurler phenotype. But again, if the symptoms are presenting in a later onset, then they can be known as hurler ski or ski phenotype, which are, as you can see, already presenting around the second decade or in the adulthood. So red flag signs are very important. If any child is having recurrent infections, rhinorrhea, all these things, we should certainly think about MPS. And regarding the age of onset, especially in MPS 2, you can see in this study, it was found like initially 1 to 2 years, it can only present with nasal obstruction, hernia, recurrent otitis media. The typical course features, as you can see, they generally present around 3 to 4 years of age. So high index of suspicion is very important for such patients. Again, this is the spectrum, neuronopathic or the non-neuronopathic form. Those having the severe manifestation, they have the severe CNS involvement. They have the neuronopathic form, and non-neuropathic, generally the CNS features are less. Natural history already discussed. So lastly, again, the onset of symptoms is generally around 1 to 2 years, but always there is a delay in diagnosis, which shouldn't be done. Thank you. Moving to the next question. Yeah.
Thank you so much, sir, for concluding and telling us from the starting and telling us about the spectrum of the features which can be seen. And now coming to this very important topic, we would also like Dr. Veronica Arora to help us in telling us the importance of early diagnosis in patients with MPS.
So I think we would be also discussing later the importance of prevention. So for all genetic disorders, there is nothing greater than prevention, and we must screen these disorders in consanguineous families and even offer such testing to preconceptional couples. So we can prevent this disorder, but if we are not able to prevent it, the earlier we diagnose it, the more useful will it be for the child. Because as we discussed about the accumulation of gag substances in different parts of the body, so as time goes or as the disease severity increases, there is increased accumulation of gag that is present in different parts of the body. One very important organ system that once affected is very difficult or impossible to reverse is the neurological symptom. So if we have any MPS which has neurological involvement, we cannot really reverse it. So to diagnose an MPS at an earlier stage, especially the ones with severe neurological involvement, we will be able to provide the children with therapies, including the enzyme replacement therapies, and especially the bone marrow replacement therapies, because they anyway cannot be given for children more than 2 years of age, the bone marrow or the HSCT. So if we are giving an HSCT, we need to have an earlier diagnosis. Otherwise, once the ship has sailed after 2 years of age, it is really of no use. And the only type of diagnosis we can give is a supportive diagnosis. So those are the reasons why we need to do an early diagnosis. Another very important reason of early diagnosis is, especially in the Indian scenario, that if you have a family who is coming to you at maybe 2-3 years of age with MPS, and the diagnostic odyssey is very long. For example, you're making a diagnosis in 3-4 years, they will have another child which will also have MPS if a prenatal diagnosis is not offered. So if we diagnose a child early in his childhood, we can offer the family prenatal diagnosis for the next child, and also cascade screening, that is screening of other family members, so that this disorder can be prevented in them. Thank you.
Thank you so much, ma'am. Since we have started early diagnosis, let's go ahead. Dr. Priyanshu, can you tell us about the screening method, the interpretation of the urinary gags, which is used in MPS patients?
So thank you. So screening of mucopolysaccharidosis can be done by interpretation of urinary glycosaminoglycan. So there can be different pattern of urinary glycosaminoglycan in different type of mucopolysaccharidosis. So the dermatan sulfate and heparan sulfate are predominantly increases in type 1 MPS, type 2 MPS, and type 7 MPS. In MORQ, which is type 4, so we can have raised keratan sulfate in type 4A and type B. Similarly, in type 6, we can have increased in dermatan sulfate primarily, and heparan sulfate is mainly elevated in Sanfilippo disease, that is type 3A, B, C, and D. So whenever the heparan sulfate is significantly increased, that shows that patient must be having neurological symptoms, which is seen in Sanfilippo disease. So there can be false positivity and false negativity also. So false positive urinary glycosaminoglycan can be seen in other lysosomal storage disorders such as mucolipidosis type 2 and 3, multiple sulfatase deficiency, and some glycoproteinosis. And false negative, that can be normal total urinary glycosaminoglycan seen in few of the MPS patient, which can be due to GAG excretion decreases with age, and then there are age-related reference values. So whenever we are doing the glycosaminoglycan, you should look for the patient age. There are different levels according to different age. And in milder form of the MPS, there can be false negative glycosaminoglycan. So you should take care with the very diluted urine specimen, because if urine specimens are very diluted, there will be false negativity, and there can be variation in the glycosaminoglycan along with the day. So the time of the day, they can vary. Thank you.
Thank you so much, sir. So an early morning urine sample collected properly and sent for analysis is a must in the screening of MPS patients. Thank you. So once we have screened, we would now like Dr. Meenakshi to elaborate on the enzyme assay techniques, which is used for diagnosis.
Yes. So historically, enzyme assays were basically the go-to tests for the MPS diagnosis. Now the first line may have been taken over by the molecular studies. We know that for each MPS, there is a particular enzyme which is deficient. So there are two main methods of enzyme analysis. First is the fluorometric enzyme assays, in which you test the leukocytes from the patient's blood or the skin cultured fibroblasts are taken care of. Second is the mass spectrometry-based tests, and these two tests and some of the patients are also offer these tests in complementary to each other. And when the test one is positive, then they usually tell us that we should go for a molecular analysis. So first of all, it is very important whenever we are sending for an enzyme analysis, the temperature, the conditions of the sample that have to be taken care of. Sometimes there are companies which provide us with free kits. The DBS sample is very easy to send because it will not be degraded. The heparin and the EDTA samples might be degraded during the transport. So you should be in close contact with the laboratory where the testing is being sent. So if we are testing for the MPS 1 and 2, we know MPS 1 is a non-sulfatase alpha-iduronidase enzyme is there, but always in testing, the lab does a control enzyme test assay as well. Usually that's the Gaucher enzyme that they put as a control. And if in case it's a sulfatase enzyme like iduronate sulfatase in MPS 2, they put another sulfatase because there is a condition called multiple sulfatase deficiency where multiple sulfatase enzymes are deficient. So we want to differentiate that this is MPS type 2 and not multiple sulfatase. So always whenever you get an MPS enzyme report, you should see that there is one enzyme and another control enzyme has been put on by the lab. Similarly, yes, like we can see in this, yes, this is enzyme analysis for the type 3 and type 4. Like I do not see the here, but maybe it has been sent for the Sanfilippo type 3B, and they have put this 2B enzyme as well. Actually, the beta galactosidase is the GM1 enzyme as well, and it has been taken as a control sample. So enzyme analysis is pretty costly affair, and the main utility in cases or in molecular era is also because if you get certain variant of uncertain significance, it does help us to reclassify the variants. And the second method that we're talking about, the mass spectrometry methods, they can also be taken into more uses when we want to provide newborn screening to the MPS patients, because they are stable. You can do multiplexing of the enzymes on these assays. And but yes, the utility and all we are going to discuss on later.
Thank you, ma'am. Thank you so much for telling us about the enzyme analysis and the methods which are used, how we can send blood samples, skin biopsy samples, as well as the DBS. Now moving on, since ma'am has already told, molecular methods are very important. So Dr. Mayank, can you please comment on the molecular genetic diagnosis and how do we correlate between the genotype and the phenotype of the patient? Does this have any relevance for the patient?
Yeah, this is very important. As already told before by Dr. Veronica, a molecular diagnosis or a genetic diagnosis further helps for the family. Apart from the proband or the person having the disease, it can be utilized for a prenatal testing or a pre-implantation genetic testing if they're planning certain future pregnancies. Also for a cascade screening for at-risk members. When we come to genetic diagnosis, as already told by Dr. Priyanshu, that there can be many cases in which false positive urinary gag report may come. For example, an infant who is having a typical coarse facial features and we go and the urinary gag is positive. We may, if we end here, we may just be having a false diagnosis of MPS 1 or MPS 2. But again, when we proceed to a molecular diagnosis, by that we mean the genetic test, which can be different ways. It can be done either by a Sanger sequencing for the particular gene in question, if you are very sure, or it can be a multi-gene panel. Suppose MPS 1, MPS 2, most of them may have overlapping features, like most of the features are quite common. Then in that case, if like MPS 1 is having, the gene is having around 14 exons or MPS 2 is having around 9 exons, it is always be better to go for a multi-gene panel or sometimes even a clinical exome sequencing with the common genes are seen. In that case, when we get a different type of mutation, that is also very important to predict the phenotype. As already discussed before as well, there are certain mutations like nonsense mutations, certain large gene rearrangements, large deletions. It has been seen that patients having such mutations have a severe phenotype. The typical clinical presentations is very severe. This is also very important when we decide for treatment, which we discussed further. Also, it was seen that patients who are having missense mutations, generally they have a mild feature. So again, genotype-phenotype correlation is also possible because if we get a particular type of mutation, we can predict the natural progression of the disease and explain to the family. Apart from that, it is also important for genetic counseling purpose for planning a further pregnancy and also to rule out false positive. Like a child coming in infancy who was having a coarse feature, facial feature, urine gag were positive, but when we went for an exome sequencing, the child was found to have a mutation suggestive of mucolipidosis too. We already know mucolipidosis do not have a ERT, but MPS 1 or 2 have a ERT. So of course, molecular genetic diagnosis is the definitive diagnosis also for the particular patient and also for the family.
Thank you, sir. So, sir, can we conclude that if we have a false positive gags, then it is better to go for the genetic testing next?
Yeah, even for a false negative case as well. See, many times urinary, we shouldn't, if we are very sure about the diagnosis, like coarse facial features, typical things are there. As already discussed, it may come false negative as well by a faulty lab technique. So whenever we are suspecting a patient with mucopolysaccharidosis, we should also always go for a definitive diagnosis by genetic testing.
Thank you.
Either it can be a Sanger sequencing or a exome sequencing. Sometimes I would like to add there are certain large deletions. For that, we have CGH based oligonucleotide microarray by which we can detect large deletions and all. Even we have MLPA kits. So of course, a genetic diagnosis is must.
Thank you so much, sir. So yes, we have now seen the clinical features, made a diagnosis. What is next? That is the management and the treatment of the patients. So moving on, I would like Dr. Veronica ma'am to please comment on what is the current standards of care for patients with MPS. Is it enzyme replacement therapy versus the HSCT or bone marrow transplantation? And what are the adverse effects of ERT? Kindly throw light, ma'am.
Hi, thank you, Sakshi, for your question. So current standard of care for patients with MPS really includes an enzyme replacement therapy, and an enzyme replacement therapy is really not available for all the sorts of MPS. All subtypes of MPS do not have a validated enzyme replacement therapy. And coming to bone marrow transplantation or HSCT, so that also is really not advisable in all MPS. It is well validated in one, still in talk for 2. So then how do we decide that which therapy we need to give? Really depends upon what is the type of MPS and upon the availability of therapies. So we do have enzyme replacement therapy for the commonest MPS, that is the MPS type 1, 2, 4. And these are the MPSs for which the which the therapies are being given in India and in all our centers as well. So now, what is the advantage and disadvantages of enzyme replacement therapy? So enzyme replacement therapy could be a weekly or a fortnightly infusion, and it is given as soon as we establish a diagnosis. A big challenge and a fallback of enzyme replacement therapy is that this therapy does not cross the blood-brain barrier. So meaning thereby that enzyme replacement therapy, even if you give it on time, it is not useful for the types of mucopolysaccharidosis which involve the central nervous system. So once you have given an enzyme replacement therapy, it will go and correct the enzyme deficiencies in different parts of the body, like the liver, like the skeletal system, like the heart, but it will not correct the intellectual disability or the speech delay or the hyperactivity or the behavior disturbances that is present in an individual, because the enzyme restricts to the other side of the blood-brain barrier. This is the advantage of what is known as the HSCT, in which the corrected stem cells go to the brain and they make new enzyme in the brain. So even in the severe types of mucopolysaccharidosis type 1, we can actually give HSCT if diagnosed at the correct time, and only when the IQ of the patient is still preserved. Once there is defect that has already settled in the central nervous system, we cannot even give the HSCT. Also, there is a time when we give HSCT, we need to cover it up with enzyme replacement therapies also. The third and now the most exciting therapy is gene therapy, which is also available for certain subtypes of MPS, though the availability in India is still restricted. So again, we come back to a diagnosis, and once we have a diagnosis, we can offer these patients so many different types of therapies, the best being HSCT for MPS type 1, and now coming on to MPS type 2 as well. And if not, the enzyme replacement therapies for the types of MPSs that have already ERTs for them in place. Thank you.
Thank you so much, ma'am, for telling us about the standards of treatment, how enzyme replacement therapies and HSCT is indicated in which conditions, but all of this requires early diagnosis and early management of patients. But how is all this possible? These are very expensive therapies, and what all initiatives have been taken up is what our next speaker is going to tell us about, Dr. Priyanshu. Can you throw some light on the initiatives done by the government regarding the National Rare Disease Policy, and what is the role of patient support groups in the treatment of these patients?
Thank you very much, Dr. Sakshi, for the question. So, as we all know that National Policy for Rare Disease 2021, they grouped the rare disorders into 3 different groups. So group 1, group 2, and group 3. So the lysosomal disorder, mainly they are treatable by enzyme replacement therapy, comes under the group 3. So for these disorders, definitive treatment is available, but the challenges are to make optimal patient selection for benefit and high cost and lifelong therapy. So the cost is very much so. It was suggested by ministry that for group 3 patient, we can raise the fund through the crowdfunding portal. However, it is not very successful. And recently they increased the RAN scheme, that is Rashtriya Arogya Nidhi scheme, amount to 50 lakhs. So they can get one-time amount of 50 lakhs for the treatment of LSDs. It's more useful for those category those can be treated by hematopoietic stem cell transplantation. For them, it is very useful. But for ERT, it is seen that ERT is so costly that this amount lasts for only for few months. in treatment. So there are now 11 centers of excellence across the country. And I already told that they can get a financial support up to 50 lakhs for each patient. So there are different organizations which is working in the field of rare disease that are like, so NSPSS, that was a very old organization. Then Rare Disease India Foundation. So Mr. Saurabh Singh is really working very hard nowadays, and he is a very instrumental and he is a key person for the development in the country in area of rare diseases, and he is doing hard work for rare disease awareness programs and coordinating with media and ministry to make the life better for these patients. Then there's National MPS Society. So these are the main organization. Apart from this, there's an organization ORDI, organization for ORDI also working in a rare disease field.
Thank you so much, sir. Yes. So so we have done the diagnosis, treatment, and we have help for the treatment now. The National Rare Disease Policy, as well as the support groups to help our patients. But as we've emphasized, as Veronica ma'am emphasized in the beginning, prevention is a very, very important role in genetic disorders. So Dr. Meenakshi ma'am, can you tell us options which are available for pregnant females with previously affected child, a previously affected MPS patient, and any role of newborn screening? So we are going towards preventive measures now. Over to you, ma'am.
Thank you. So as we all know that most of the conditions in genetics are not treatable. We are fortunate that we have ERT for MPS, we have HSS, CT for this, but as we all know, it's very costly and beyond the reach of common man. Even the national policy is not going to cover entirely the exuberant costs. So it's very, very important whenever we meet a patient of MPS, we should strive to give this preconception, carrier screening and the other carrier screening and the other prenatal diagnosis information to the patients. So if I have a patient in which I have a diagnosis at hand, most of these are autosomal recessive conditions. The MPS 2 is X-linked conditions. So if I have a diagnosis of an autosomal recessive mucopolysaccharidosis like 1, 3, 4, then I know that the risk of reoccurrence is 25%. And I educate the parents that we have the mutation diagnosis. It is very important that the mutation you have in hand is a likely pathogenic or a pathogenic one. And if it is better to get in consultation with the clinical geneticist to know that the mutation is well correlating with the disease phenotype. And then when we are confident that the mutation is the causative one, then only we undertake the prenatal diagnosis. So in the prenatal, if you have a report which says the uncertain variant, then you go back. What we do is we do a genotype-phenotype correlation. We look at the enzymes and the other features. So the prerequisite to a prenatal diagnosis is a likely pathogenic or a pathogenic report. So I have a patient who has an autosomal recessive MPS and the risk of reoccurrence is 25%. So if the patient comes to me, I'm going to advise that there is either CVS option or amniocentesis. CVS is done at 11 to 13 weeks of pregnancy, where we take the sample, a chorionic villi sample, ultrasound guided, and the risk of abortion, miscarriage in this procedure is little, as much as 1 in 250 to 1 in 500, quite a safe procedure. The results are available depending, usually in 20 to 30 days, and they are 100% reliable results. And then the family can go ahead with the continuing or terminating the pregnancy. If a patient comes to you later on in pregnancy, or they are not willing for CVS, then we can go for the other test, which is amniocentesis. Amniocentesis is done beyond 16 weeks of pregnancy. And here you take out fluid from around the baby, that is the amniotic fluid. And in the amniocytes, we look at for the same mutations. Again, the results are available and we take the decision to continue or not to continue. So this is done when the patient comes to us in the pregnancy. And for MPS 2, we know it's X-linked. So the same methods, just the inheritance pattern varies. The risk of reoccurrence is again 50% of the males are going to be affected. The other is if the parent comes to you before conception, there is another option of PGT is available, PGTM per se. That means pre-implantation genetics. So in very simple layman term, it means I take the embryo, I take the egg, I form embryos, and these embryos are tested. And we know that approximately 25% of the embryos are going to be affected. We discard those embryos and we implant the healthy embryos. And this is another method. This is quite costly, but yes, those couples who have unfortunately suffered it yet again, and in certain countries where termination is not allowed, this is also an option. The third option is if sometimes due to the diagnostic odyssey or due to the poor ovarian reserve or whatever, there is the patient cannot conceive naturally, the IVF PGTM is too costly for them, then donor gamete, either a sperm or egg DOA, is also given as an option. So the main thing is that we should take every opportunity to guide the parents about prenatal diagnosis. A very important thing that, as Dr. Veronica said, was preconceptional carrier screening, the expanded carrier screening we have, where we can, if there is a family history of MPS, we should also extend carrier screening to the other family members. It's very important to sensitize the patients that you should inform this to your near and dear the family members, so they can be screened as well. So screening till we have better resources for the treatment, I think prevention and prenatal should be really stressed upon every opportunity that we get. Thank you.
And ma'am, the role about newborn screening.
Oh yes, sorry. The newborn screening.
Yes,
newborn screening is MPS disorders are very apt for newborn screening because we have treatment. So always the newborn screening disorders are the ones where you have treatment which is highly effective. So they do qualify for newborn screening very well. We have such good testing for them. We have fluorometric, we have mass spectrometry. You can multiplex all these enzymes. The cost effectivity, we do not know our prevalence rate, but by our experience, we do not have the data, but we know that they are fairly prevalent. So they do qualify. But the ground reality is that we are not being able to provide newborn screening for many more conditions. In an idealistic world, it should be incorporated. Utility wise, it might be a little below the long line of other genetic disorders for which I might want screening. But yes, we should screen for that also. NBS is a very good, we might not get as much yield as with other conditions, but yes, in near future with the costs coming down, we should promote it. But still, I think preconceptional and prenatal would still take more of a role as compared to newborn screening till then. Thank you.
Thank you. Thank you so much, ma'am. I agree that prenatal and the amniocentesis, the counseling for all the prenatal diagnosis is very, very important. The genetic counseling is very important. But yes, if we want screening more strong, and if we can go forward, then yes, why not? The future, we can include mucopolysaccharidosis. Going on to the newer therapies, Dr. Mayank, would you please like to tell us about the newer novel therapies which are there in pipeline, and what is the status of gene therapy?
Yeah, as hope I'm audible. We all know this decade is going to be the era of gene therapy or therapy for most of the genetic disorders, and clinical geneticists are going to play a big role. Already discussed before, there are certain shortcomings with the present therapy or treatment available. Like for enzyme replacement therapy, if you go, we all know that availability is a big concern for a country like ours. Cost constraints are there. Apart from there, a major limitation that they cannot cross the blood-brain barrier. The neurological disease, it may not reverse. Apart from that, there even for HSCT or hematopoietic stem cell transplantation is not suitable or successful for all the different MPS. So there was always a search to find certain other newer therapies, and certain very good newer therapies are in the pipeline. First, I would like to let you all know about the small molecule therapies. These are certain small molecules which have the advantage of taking orally. They are cheap, they can cross the blood-brain barrier. So obviously this is going to be a great thing. And already such a small molecule therapies like substrate reduction are being tried for certain other lysosomal disorders like Gaucher, Fabry and all, even for Niemann-Pick disease. So substrate reduction is one of the way which is also being tried for MPS patients. There are the trials. Then we have certain chaperone therapy, which is something like if little bit of enzyme is there, we are trying to pharmacologically support it so that it can function in a normal way. Apart from there are certain very good therapies, especially for those patients who are having nonsense mutations or who are generating stop codons. These are the stop codon read-through therapies, especially being trial for MPS 1, 3, and 6. So hopefully that will be a great success. Apart from that, when we come especially to the gene therapy, by which we mean there are certain viral vectors through which we transfer a transgene to the patient. So it can be either ex vivo or in vivo. In vivo, this gene therapy, especially using adeno-associated viruses, has been tried, especially in MPS 3A patients, and it was shown that the intracerebral injection of the viral genome led to the neurological improvement, which is a very good sign. So hopefully in future it will be available for most of these other MPS. And when we come to ex vivo gene therapy, it was like using the lentivirus viral vectors. Certain hematopoietic stem cell, the stem cells were transcribed ex vivo, and then they were transferred to the patient. Obviously, this is also under trial. So there are certain other lot of therapies under research. Main aim is to cross the blood-brain barrier to decrease the cost. But again, always there is a caveat, especially when we go for a viral vector-associated gene therapy. There are also the chances of pre-existing antibodies in the patient in which this therapy won't work. In fact, that works for ERT as well. Some patients will have pre-existing antibodies for various ERTs. So all those things need to be kept in mind. But of course, there is a good hope. And in future, we may have therapies, ERTs, or even this gene therapies for almost all the MPS. Thank you.
Thank you so much, sir. We've had a very nice, informative, in-depth session with all our panelists, and we have come to an end, coming from clinical features, diagnosis, treatment. Thank you to all our panelists. And we have a question in our Q&A. If Ananya, you could help me. Mukesh Amarnani has many questions. He wishes to be unmuted.
Oh, ma'am, we cannot do that.
I think we will be able to. Ananya, why can't we do that?
Ma'am, let me just check.
Yeah, maybe you can send him a panelist link.
Just a second, ma'am, I'm checking. What was the name of the participant?
Mukesh Arnani.
Okay, got it. Yes.
Yeah.
Meghna, you have to give him the access to speak.
Yes.
All our other questions have been answered so well in the Q&A by
Yes,
Dr. Maya and Dr.
Hello, am I audible?
Yeah, you are audible.
Thank you.
Hi, good evening.
Hi, good evening. Thank you for this awareness session. I'm having total 4 questions. But before asking the question, let me give the background. My nephew is having around 3.5 years of age, and he's diagnosed with MPS 2 Hunter syndrome. And he's diagnosed before a couple of months, like that 4 to 5 months back. And right now, we already done the bone marrow transplant is already done. Today is going to discharge from the hospital. Okay. So my question is that we done a couple of the reports, like we done the enzyme report, GAG report, and now we found that my sister is a carrier. Okay. So my first question is that my sister is a carrier, but my mother, that means it obvious that if my sister is carrier, my mother must be also a carrier. But I am the son, so I am not affected. Apart from that, my nanima was having 2 sons, so none of them was having the MPS. So and my Masi is having a daughter, 2 daughters, and their son and daughter, none of them having MPS. So how we can make sure that is happen? What is the reason to happen with my sister? Second, my question is that
okay, Mr. Mukesh,
let's
pause for 1 second and just tell us about the clinical features of your nephew and who did you meet for it? Like, did you meet a clinical geneticist or?
Yes, we met with couple of the geneticists at the Gujarat. We met with one doctor, Ashka Prajapati, and now we are at a Bangalore. So we met with the Dr. Meenakshi. The features, initially it was not, diagnosed. It takes a very lot of, because we belongs from the very remote case called as in Kutch Bhuj, where the pediatrics is not able to find it out. But anyhow, the doctor Harsh Patel from Ahmedabad, who identified it might be the child is having might be the MPS. So we done for the X-rays, and J-shaped Shenga and the legs were getting bit banned. So based on that, he having a doubt. So we gone for the X-ray, and then we done for the reports. We done reports with the Jay Sheth at Ahmedabad, and yeah. So this kind of the reports we have done. So now my question, first question you got. Second question is that we already finished our BMT. The bone marrow transplant is successfully done, but as you said that the doctor decide should we go for the BMT or not is depend on the neurological condition of the child. So we done brain MRI is done, but the brain MRI the doctor asked for the this pediatric development. So pediatric development is done. The doctor said it is the child is having 50% behind from the age. Okay, but then also they suggested go for the BMT. So what will happen according to your experience and according to the data you do have it? What will be happen with the child after the 20 years? Will it be the 50% behind from this, like in the age is 20 and behave like a 10, or it is right now his child is having a 3 years and it will be behave like an after 20 years it will be age mental age will be around 17 to 18 years. And second thing is that before the BMT we done the Bera test. It was found that profound hearing loss was there.
Yeah.
Right. So what will be effect on that? We recovered from that? Okay. And third, my question is that, as you said, that government policies is there, but what I heard that the government has removed the MPS right now from the rare disease, and it is discussion is going on that mean they will aid in the future again the rare disease. So what is the status, if you have any idea on that same? And fourth question is about my gene therapy. The last session we done on the gene therapy. So will it be possible for if it is for the person, the child who's undergone the HSCT, is it okay to perform the gene therapy on that? What will be the cost and what are the success rate chances? If you can, throw some light on the same. Thank you very much. So these are my total 4 questions.
Okay, number of questions. So, Veronica ma'am, would you like to start?
Yes.
Yeah, so I'll just take the first question first, and we can all take each question. So I think the first question was about that the child's mother is a carrier. So Mukesh, you can please let me know if you're with me. Okay, if there is a confusion, you can ask. So the child's mother is a carrier. So she is XX. That means that one of her X chromosome has a mutation. Is that okay?
Yes, please.
Okay.
And I just wanted to know that before the baby boy, she that means my sister is having one daughter, and she's absolutely fine, and she's 8 years old.
Okay, so now she is a carrier. That means she has 2 X chromosomes. One of the X chromosome is not functioning. Now, if you go to her mother, so her mother again has 2 X chromosomes also. So that doesn't mean that her X chromosome needs to be mutated. The first time the mutation may have come in the child's mother, that is your sister. So it is not necessary that the child's grandmother is a carrier. Do you understand what I'm saying? There is something called
I got your point.
mutation. That means the mutation must have occurred for the first time in your sister and not in her grandmother. That means you are not at risk of having this problem. And because your sister has a mutation in one of the 2 X chromosome, so there is a 50% chance that her daughter is a carrier. Because
Right.
if the normal X goes, she's not a carrier. If the mutated X goes to the daughter, she would be a carrier. So the chance of her daughter being a carrier again is not 100%. It is only a 50% chance that the daughter is a carrier. We don't need to do her carrier testing now. We can do it much later when she's an adult and when she's interested to know her carrier status. Okay.
Okay. So,
Thank
okay,
you, ma'am.
fine.
Okay.
What about the
So
second
the
question?
next question was about, there was a 50% delay in the development and they had gone forward
Yes.
with the BMT.
So would
So-
anyone else like to comment on it? That
Dr. Mayank or Dr. Meenakshi? I think Dr. Priyanshu is not there.
So I think the question
Dr.
is that there
Meenakshi.
was a neurological delay and bone marrow was done. So
Yeah, so I just wanted to know that what will be happen in the future. That means after 20 years, that means how the child will perform.
See, Mr. Mukesh, hope I'm audible. See, whatever the patients have been seen for, especially regarding Hunter syndrome or MPS2, probably the same disease in your family, whatever research has been shown, like Hunter outcome survey, which was done for decades. One thing which we also reiterated many times, that even for ERT or HSCT, if performed very early at an early age, it is helpful. But in all these patients, most of the patients were seen that behavioral abnormality, neurocognition delay is quite a common feature. Generally, this may persist because if before transplant you are saying that he was having certain neurological features or something, IQ was around 50, you were saying, probably I may have misheard.
Yes.
As per the present data available in the literature and various researches, one cannot guarantee 100% improvement in the intellect. So that will be, of course, guarded. I think Dr. Meenakshi may add or Dr. Veronica may add to this.
Dr. Meenakshi, ma'am, you're not audible.
So there is because there is a higher neurological involvement, so that delay deficits would be there. And from the limited data which we have, usually the literature studies which we have from the different countries to look upon, as Dr. Mayank said, the prognosis would still be guarded. The non-neuronopathic types do quite well, but the other ones, they still have a guarding because some amount of damage has already been done. So that wise, it is going to remain guarded. We cannot say that it's going to miraculously cure it 100%. Time will tell, but definitely some cognitive deficit is sure to be there.
Yeah, I can understand that some disorders will be there, but I just wanted to know that, right now the child is around 3.5 years old. The doctor said the mental age of his child is 50%. So what do you mean by the 50%? And what will be the function in the next 20 years? Will it be 20 years? We can say that the child, the physical age is 20 years and he will behave like a 10 years, or it is just 1.5 years behind from his mental age growth.
If somebody is telling you that the development quotient is around 50%, that means if the child is 3 years old, he's doing mentally, he's doing the motor and the speech milestones at around a child of 1 year. Like maybe he's 3 years old. The speech is like he's forming a few words, speaking a few words, which is like a 1 year old. So, and he's just started walking. So that means 50% means he's lagging. He's doing the developmental milestones are what should be for a the child half his age. It doesn't mean that if he's 20 years old he'll behave like a 10 years old, or he'll be, definitely doesn't mean that he's 20 years old and he'll behave like 18 years or 1.5 years. That's nothing there. That cannot happen. It definitely means that there would be some amount of cognitive impairment would remain. And if the child, that time is only going to tell if how much speech the child has attained, like what is the cognitive ability. But definitely if the child is 20 years, he's not going to behave like a 14-year-old. There will be some cognition in the range. From our experiences in literature, we can see that the child might have mild intellectual disability kind of a phenotype.
Thank you so much, ma'am, and thank you, Mayank sir, for answering these questions. And we can agree that the National Rare Disease Policy is still covering MPS patients. It's not that it has removed them or there is any talk of that. It is still there. And moving on, I think there is another question in the chat box.
I think one more question was there regarding
Oh,
gene therapy and HSCT.
yeah.
So I would just like to add to Mr. Mukesh, like see, hematopoietic stem cell transplantation, it has shown very good results for MPS 1 and metachromatic leukodystrophy, certain other conditions. When you are talking about MPS 2, the result has been variable in worldwide studies. Okay, and I will again repeat, if certain, for example, I give example one published literature, a 70 days old child was given this therapy. In that child, of course, there was a very normal course of life, but again, HSCT is also not curative, and various researchers have shown HSCT combined with enzyme replacement therapy or combined with certain newer therapies like a small molecule therapy or gene therapy will always going to be best. So again, you always have a chance to enroll for any gene therapy associated with MPS 2. But whatever I know at present for MPS 2, generally we don't have any FDA approved gene therapy, but of course things are going on. And hopefully if something significant comes out, you can enroll for gene therapy as well.
But sir, what I heard about the gene therapy, it is same as a HSCT. As early as you do, it is good.
Yeah,
because the virus.
but again, what I mean to say, if you are getting something and no particular harm is there, no need of opting it out. Hopefully, you are still saying that the child is having bit of developmental delay. Already it was received late. So what I mean to say, especially for MPS 2, I agree at present no special gene therapy is there. But if you get a chance, no harm in enrolling after knowing the pros and cons of the gene therapy, because gene therapy per se may have certain other implications as well.
Okay,
So
and
you don't want closed completely. What I mean to say, we can always try for other therapies, small molecule and all. Yeah, continue.
So gene therapy is also not that means whatever the damage is already done is done. Can recover that as well through the gene therapy?
Very tough to say, but mostly the damage which has already been done, it won't reverse as per the present data available. But again, we can try.
Okay, thank you.
So for the other, except the neurological manifestations, all your size of the liver, the cardiac accumulation, all that will reverse. The neurological manifestations would not reverse because there is already damage and breakdown of the neurons due to the toxic chemical to reverse. That is the thing.
Yeah, but in our case, only this is the the big change, because other things are very good. Child is not also child is also looking like a normal child. So this is the only challenge we do have it right now.
So that means he has a mild type of MPS 2. So actually MPS 2, if it is mild, the children do very well. So I'm sure that your child will also do very well. And I'm sure this decision of doing a bone marrow transplantation was taken after seeing the development, etc. And the development will not worsen henceforth because we have already done the bone marrow for this child. So there will not be much worsening, and slowly stage advances. Child is definitely likely to improve as his age advances. So there is all good for him in the future, including this advent of gene therapy. Of course, if there is a trial of gene therapy, it will be difficult for you to get him enrolled in the trial because there would be an exclusion of other therapies, because otherwise it would be very difficult for them to bring us to the gene therapy, right?
Thank you so much, ma'am. I think that resolves all the questions for Mr. Mukesh. Now, going on to Dr. Meenakshi, who is going to answer, I think, this question. Any pointers towards which particular enzyme? Okay, that has been answered by sir. So I think we have completed our Q&A session. I would like Dr. Saurabh Singh to now deliver the vote of thanks. Thank you all the panelists for such a lovely, informative session.
Yeah. Hi, everyone. It was really a very wonderful session, and I'm really very thankful to all of you who are present here and given a brilliant speech on this National MPS on National MPS Awareness Day. And before I close, I wanted to share a small thing. Behind all this, I am also a parent of a MPS child. My son is MPS 2, Hunter syndrome, and he's 11 years old now. And I want to share one story. I belong to a very small place. I am based at Ranchi, Jharkhand. Earlier it was a Bihar. When, you know, in this remote area, the awareness of rare disease are very less. Nobody knows about rare disease, what is rare disease, what is MPS, and what is this, Gaucher diseases and everything. Whenever I go one doctor, after some times, one doctor asked him to go another doctor, then another hospital, another place, another city, another state. So these chains are, this is not only my story, this is the story of all the rare disease patients. And now I'm very thankful that you all are there, and you all are teaching our new generation doctors who are doing MBBS and all. So most of them are also attending this webinars through not for this webinar. We also organize so many webinars, and now we have the National Rare Disease Policy so that the patients can get the benefit out of it. When my son was diagnosed in 2014, there was no such policy. Only 3 lakhs rupees was given by the state government for this any treatment of these diseases. I approaches to so many politicians. I approached to the Chief Minister, Health Minister, Prime Minister, even President of India, and so many people. But the answer was same. Prime Minister Relief Fund, you can get 3 lakhs rupees. President given 1.5 lakhs rupees. Chief Minister advised me to get 3 lakhs rupees. So all these money are useless. You know, the cost of the therapy comes in crores of rupees. No individual can afford. So we need a National Rare Disease Policy. After the struggle of all parents like me, we together fight for this National Rare Disease Policy, and now this policy in place. And this policy, under this policy, revised policy, we are getting 50 lakhs rupees for treatment of rare disease, but that 50 lakhs rupees is for treatment of group A and group B of group 3 A and B category of this diseases. So this is not sufficient from group C, like lifetime therapy patients. We are still fighting for this revised national policy. We are requesting government, and government is also really working very hard. We are in the discussion with the government, and they are also thinking about positive thinking are there. So we hope that one day, the day will come when we will have the proper policy in the country. So, but for nowadays, the policy is for only 50 lakhs rupees is supported by the government of India for all the rare diseases, including the lifetime therapy patients. So this is the answer of the Mr. Mukesh who asked earlier. So thank you so much, Dr. Priyansu, Dr. Veronica, Dr. Meenakshi, Dr. Sakshi, and everybody, and stands also to support us. And thank you, Akash, for coming for this webinar. You are the you are the person who motivates the patients. We can learn from you. You are doing wonderful, and we can also learn that the medicines are really working. And after getting this medicine, anybody can be cured. This disease can be cured. So thank you, Akash, for coming online. Thank you, doctors. Thank you so much, and all the best, all the very best, Akash, for your future.
Thank you, sir.
Thank you.
Thank you so much.
Thank you so much.
Thank you so much, Sakshi. Thank you.
Thank you, Dr. Veronica.
Saurabh. Thank you,
Thank
everyone.
you.
Thank you, everyone.
Thank you, everyone. Bye.
Thank you, Ananya.
Thank you so much, everyone.
Thank you, everyone. Thank you. Thanks a lot.
It was nice meeting everyone. Thank you.